Welcome and thank you for joining us today. We are Pre-Health Shadowing, an international nonprofit organization. Our mission is to empower aspiring healthcare professionals by providing virtual shadowing opportunities. And thank you so much again, and we are thrilled to have you as part of our community today. And your participation and support are crucial in driving forward our shared goals in the medical field. So, as part of our commitment to inclusivity, we provide closed captions to support students of all abilities and needs. We value your feedback and are also always looking forward to improve our access. So, if you have any ideas or suggestions, feel free to email us at info@prehealthshadowing.com. Also, to ensure that our communications don't get lost in your spam folder or anything, please save us as a contact, and by joining our email list, you'll never have to miss a session update. Other than this, we're also on Instagram at Pre-Hot Shadowing, and if you're on TikTok, then you can find us there too with the same handle. So please don't forget to sign up for our email list because it's the best way to ensure that you're always informed about our latest sessions and opportunities. Secondly, we are thrilled to welcome students from all around the globe, and it's always fascinating to learn where everyone's coming from. So, for example, my name is Manasvi Sharma, and I'm from San Jose. So, feel free to share in the chat where you guys are calling from today. Panama, Los Angeles, California, Atlanta.
Yeah.
Thank you guys. Colombia, wow. They've got a diverse space here. California, Los Angeles. New Jersey. Yeah, thank you guys. Okay. And also, if you're interested in being part of pre-health shadowing, we have a fantastic opportunity with you. And you can join us as a volunteer. And this is completely remote, so you can contribute from anywhere in the world. And to get started, just register on our website, and you can gain valuable experience and make a positive impact in the pre-health field. So, yeah. And other than that, if you have any questions, feel free to visit our website for more information. Other than this, we're also recruiting for our leadership team, and it's open to everyone. So, this is your chance to apply your skills, learn new ones, and also make a real impact, all from the comfort of your home, because it is 100% remote. And if you're interested in this opportunity, just head to our website and fill out the application form. So some of the available leadership roles here are listed over here, and we're looking for leaders in all these departments. But if you feel like there's something else that's not listed here, you can also propose your own department or role here if you feel that it's going to holistically help PHS. So yeah, if any of these roles resonate with you, I encourage you to use the link provided here to join our team. Other than this, our high school training program, or HTP, is another fantastic way to gain valuable skills and insights in both leadership and health skill fields before you step a foot into the college campus. All you need to do for this is to fill out the interest form available on our website. Also, our entire operation on PHS relies on the generous donations and all the time contributed from our dedicated volunteers. And because this is what allows us to continue offering opportunities to learners from all backgrounds and walks of life. So if you have the means, I would really consider making a donation. And even every contribution, no matter the size, even if it's like $1, it helps us maintain and grow in this inclusive educational experience. During the session, if you have any questions, feel free to type them in the chat because we want this to be as interactive and informational as possible, so please don't hesitate to participate. After completing the session, you'll have the opportunity to earn a digital certificate. And what this certificate does is basically verify your hours and that can be accessed at our professionals course page at Pre-Health Shadowing. And it's important to take good notes during your shadowing experience today because these notes will help you during the assessment, but also enhance your learning. And then if you guys could turn on your camera, that would be really, really great because this approach aims to replicate more of like an in-person environment, enhancing the experience. Okay, and finally, I'm pleased to hand things over to our professional today, Dr. Newton, and we'd love for you to share a bit about yourself and just take it from here.
Okay. Y'all can hear me?
Yeah.
Yes, okay. I grew up in Western Pennsylvania, up above Pittsburgh. I got my bachelor's degree in biology from Slippery Rock University in Slippery Rock, PA. I did 2 years of a master's degree at Eastern Kentucky University in Richmond, Kentucky, and then didn't finish it. I transferred 30 miles north to the University of Kentucky, where I got a PhD in anatomy. And after that, I spent 4 years doing postdoctorate work in neuroscience at the University of Rochester, Rochester, New York. Took a job at the University of Arkansas for medical sciences in Little Rock, and I spent 2 months shy of 25 years there teaching gross anatomy, neuroanatomy, histology, and embryology. Uh, then I left in 2013 and came to Campbell University School of Osteopathic Medicine, and I retired from there at the end of 2022. But I am now what is called a standardized patient for the osteopathic medical students there. And I'll describe what that is just a little bit later. And right now, I'd like to give you the presentation about the importance of clinical empathy. So let me share my screen and we'll see how this is going to work here. I got to hit share. Okay. And we'll put that up there and we'll make it full size. I'll move you on over so I can see. Okay. Well, that's me. I'm a retired professor and chair of anatomy, and I will talk about clinical empathy. You can see the side of the screen where the whole word says empathy. Yes? Okay, good. All right. So, you may not know what empathy is, so we'll start with the definitions first, and then we'll go on to why it's important clinically and how we found out that empathy decreases during medical education. All right, there we go. That's the button I hit. Two definitions for empathy because there were two different types. There's something called affective empathy. All right, a person's vicarious or internal emotional response to the emotional experiences of other people. It's like a gut feeling that you get when you're in an emotionally charged situation. And as a future healthcare professional, you will be in those situations. Then there's something called cognitive empathy, and that's a person's ability to use their imagination, right, to predict and understand the person's thoughts and feelings. All right. Then in 2001, Dr. Hojat, who is a world's expert in empathy, devised the term clinical empathy, which is basically the same thing as cognitive empathy, but in a healthcare setting, right? That is a predominantly cognitive as opposed to affective, right? So it's not emotional. It's an attribute that involves understanding as opposed to feeling it internally, the patient's pain, experiences, concerns, and perspectives. And then to make it clinical, he combines that with the capacity to communicate this understanding and also have an intention to help. So those last two things make it clinical cognitive empathy, basically, because as a healthcare professional, you will want to communicate with your patients and you will want to help them. All right. Empathy is not the same as sympathy or pity. All right. A lot of people confuse this. Sympathy is feeling for someone else versus feeling with them. Okay. You can feel sympathy for a person who's sad and have some compassion for that person, but you yourself will not feel sad. All right. Patients despise sympathy. They don't like to get it from a health professional because they equate sympathy with pity. And pity is a more primitive emotion. You feel sorry for the person, right? But you don't have any stake in their outcome of what they're dealing with. All right. Patients don't like that at all. In the vernacular, or in very base terms, sympathy or pity is better you than me, whereas empathy is I could be you. And that's the difference. And what we're going to be talking about here, the rest of this presentation, is about affective as well as clinical empathy. Now, when I started to study this, I'm a basic scientist. I didn't have any really good knowledge about the social sciences. So I had to read a stack of reprints and publications, probably 3 feet high. And I am not kidding you on that. And one of these things is called theory of mind. And very basically, theory of mind means you recognize that there's another person out there that's not you and that they have emotions and affective states. All right. Cognitive empathy is very, very closely related to this theory of mind. All right. Thinking about the other person's emotions or their affective state is cognitive theory of mind. You're thinking about what is that other person experiencing? What are they trying to get across to you? That's not verbalizing it or speaking back to them. That is cognitive empathy. All right. So, cognitive empathy is your ability to understand the feelings of another individual using this theory of mind without you being in an affective or upset state yourself. You can have an understanding that someone's sad without making you sad. Okay. So that's kind of theory of mind. It's still kind of fuzzy to me, but that's the way it goes. Now, it's interesting that the brain uses different parts in order for you to express affective or cognitive empathy. And there were lesion studies that have been done where people suffered traumatic brain injuries or had tumors, and they would knock out little areas of a person's brain. And sometimes that person would not be able to have affective empathy, but could express cognitive empathy and vice versa. And just a little tiny background on that. Excuse me. If we take a look at the lateral side of the brain, right? This is a human brain. It's been taken out, and you're looking at the side of it. And in individuals that are alive, you can do what are called functional MRI studies. They give the person certain scenarios or whatever, and they think about it. And when they're thinking, they're using certain areas of their brain, and those, in essence, light up, so to speak. So here we're looking at the side of the brain, okay? And if the person is expressing affective empathy, then it lights up. Wait a minute here. I think I know what to do. Laser pointer. It can be taught after teaching for 36 years. If a person's thinking about affective empathy, something called the inferior frontal gyrus lights up. If it's cognitive based or it's theory of mind, then you're getting what's called the superior temporal sulcus, this little divot in here. The neurons in there use more glucose, more oxygen, light up, and that's cognitive empathy or theory of mind. And this junction back here between the temporal lobe of the brain and the parietal lobe of the brain. So those two areas light up on the lateral surface. Now you can go in, here's another brain, human brain, and they've cut out part of the frontal lobe, parietal lobe, and part of the temporal lobe. And deep in that, there's some more cerebral cortex, more of your higher functioning brain, so to speak. It's called the insula, the island, right? Hidden from view. Those light up like crazy with an affective empathic response. There's the anterior aspect of the insula, and then something called the amygdala, which means almond in Greek. And it is a series of neurons that allow you to recognize emotions in others and to detect fear and joy. It really involved with emotions quite a bit. Finally, let's cut the brain right in half, zoop, and look at the interior. And once again, for affective empathy, it's an area right here called the middle cingulate cortex. All right. This is the corpus callosum. That's the big white fiber tract that connects one side of the brain to the other. And the gray matter, the neurons that surround it, is called the cingulate cortex. So that lights up with affective empathy. And then for cognitive empathy or theory of mind, it's the medial aspect, the middle aspect of the parietal lobe. And then way out here in front, the dorsal medial aspect of your prefrontal lobe. So those areas light up. So that's just a primer to kind of give you an idea that there are differences. The linchpin for you to express cognitive empathy is called the ventromedial prefrontal cortex. You damage this area, you cannot express cognitive empathy. It's gone. But you still have all your affective empathy because those sites have not been damaged. So there was a person named Walter, Dr. Walter, and he proposed, pardon me, two things, that there was a high road for empathy, top down, and a low road, bottom up routes to express empathy. So what does all this mean? Here's the other person. Here's their affective state, what they're trying to, it's their emotions that they're expressing. The low road here goes up and activates these main areas, anterior insula, medial cingulate cortex, and the amygdala. Those are more primitive areas of your nervous system. All critters have these. So that's the low road. It's bottom up and it's heavily involved with what's called the pain axis. If you are in pain, those areas light up. But interestingly, if you see another person in pain, those same areas light up. All right. And they'll be more highly activated if the person in pain is somebody you're close to, your spouse, your kids, right? Uh, Close friends. The closer you are with that individual emotionally, the more heavily those areas light up. That's bottom up. But then you have a high road. These are the more advanced areas of your brain, your cerebral cortex, right? Things that developed later, evolutionary wise. The temporoparietal junction, the dorsomedial prefrontal cortex, that communicates with the ventral medial prefrontal cortex. And so does affective empathy sites. They communicate back and forth with each other. And we'll find out in the next slide that the low road, affective empathy, enters your nervous system first, talks to the VMPC, that connects with the areas dealing with cognitive theory of mind. So you get this gut feeling coming up, and then you start to think about it over here. And then you want to express something back to the patient, actually verbalize, talk to them. That goes back to the ventromedial prefrontal cortex, and then you express cognitive empathy. Okay? So studies show the affect of that low road going to primitive areas of the brain arrive first. Then you think about it, theory of mind, and then you express it as cognitive empathy. So you're thinking about how to express your feelings back, in this case, to the patient, because you're a health professional, soon to be. That's what you all want to be, okay? So that's how this kind of works. So affective empathy, gut feeling. Think about it, then you can express it via your cognitive empathy. All right. So, why is clinical empathy important, and how did I ever start thinking about this in the first place? Well, uh, as I told you, pardon me, I'm what's called a standardized patient. And this is what that means. Um, in my case, medical students need to practice how to do a history and a basic physical on a person. And as a standardized patient, that's who they practice on. Each of us, no matter, I'm given a case to memorize and answers to give back to those students when they ask questions. And let's say I'm seeing 7 students during that session. I have to give the same exact answers back to those 7 students. And I'm not the only standardized patient. There's about 14 of us. So all 14 of us are giving the same answers back to the questions that the students ask. And that way the faculty can judge how well the student is doing or what they need to improve on. Okay? It's lots of fun, actually, to watch them learn how to do this. One of the things the students have to ask about, for example, is a past medical history. They'll ask me as a standardized patient, have you had any past diagnoses? I say, yeah, hypertension. Well, when was that diagnosed? Well, when I was 39. Well, I had any prior illnesses, hospitalizations? Yeah, pneumonia when I was 45. Immunizations, Any surgeries? Yeah, I had my tonsils removed when I was 4. Any prescription medications? Yeah, I take lisinopril. How much? Oh, 5 milligrams in a pill every morning. All right. So I would give those same answers to those questions to my students along with the other 13 standardized patients. All right. Now, as a standardized patient, many of the clinical scenarios that we memorize, there's a death in part of the family history that the students have to take. Okay. They'll say, are your mother and father still alive? I say, yeah. Well, how old? Well, my dad's 79, mother's 75. Do they have any health problems? And you give them the answers. Any siblings? Yeah, I got a brother. He's healthy. Uh, do you have any sisters? Well, I did, but she died when she was 25. Oh, I'm sorry. Did she have any health problems? No. But did she die of a car accident? I'm sorry to hear that. Okay. But there's no sincerity in what they are doing. When I or other standardized patients say that one of their parents or a sibling has died because of the case says that, they give very pat, standard, robotic answers. They usually just say, I'm sorry, or they'll say, I'm sorry to hear that. There's no sincerity in their response, and almost all the time, they're not making any eye contact with the standardized patient. They have their head down, they're taking notes. All right. So it's shallow, it's hollow, it is not sincere at all. Okay. And that why? Why does that happen? Okay. So we do studies way back uh, when I was in Arkansas. I did an empathy study. I was in a group of physicians, actually, even though I'm a PhD, we are supposed to do a project. And a big thing back in the mid 90s was professionalism. The American Medical Association was concerned about it. One aspect of professionalism is empathy. So I was put with a group of 4 physicians to come up with a project, and they mentioned professionalism and empathy. And they looked at me and they said, go to work, because they were too busy doing their clinical stuff. So that's how I started to study empathy. And I was the first one to look at affective empathy among medical students, and the first one to do what's called a longitudinal study. I was able to gather data for all 4 years of these medical students as they were getting their MD degree. All right. And out of all the students over 4 years, 419 of them took this survey I'm going to give all 4 times. Okay. And I not only looked at what their affective empathy was going to do, but was it related to what specialty they wanted to go into? All right. Now, this is about allopathic or MD medical students, but these results may be representative of other health professionals. Cognitive empathic studies and affective empathy studies have been done on PAs, PTs, nurses, dentists, veterinarian students. Okay. So even though I'm looking at MDs here, it can be representative of other health professions. Okay. So a guy named Dr. Albert Moravian developed the Balanced Emotional Empathy Scale, which looks at affective empathy. And I used it at the beginning of every academic year. Okay. And I gathered it, the M1 data, medical year 1. That was during orientation. The students never had any medical school classes yet, right? They were in the first 3 days of orientation for their medical school, so no classes. And then I did it at the beginning of the sophomore, junior, and senior years. Normal values, men have a value of 29, women 60, which went to prove that women are more empathetic than men. This is one of the first studies that Dr. Morabian showed this in a normal population. It was always assumed women are more empathetic. Well, here was proof. When they did the surveys, the scores were normally twice as high. And I also asked the students which one of 23 specialties they would like to enter every time they took the B's scale. Okay. Boom. Okay. Next. There we go. I broke up the 23 specialties into what I called core and non-core specialties. Core specialties is where the health professional has increased patient contact and continuity of care. They're people oriented, right? Family med, internal medicine, OBGYN, peds, and psych. Because these physicians or other health professionals see their patients multiple times. And then there were the non-core specialties, little or no patient contact and lack of follow-up care. Examples, anesthesiology, emergency medicine, general surgery, path, radiology. How many of you out there go for your yearly checkup to your anesthesiologist? I mean, nobody does, right? But you see your family medicine doc or an internal medicine doc. Okay. So, anesthesiology, emergency medicine, general surgery, they'll see patients, but in a very limited context. Things like path and radiology, they don't even see the patients at all. They're either reading samples taken from the patient or they're reading x rays or MRIs. So, more technically oriented, okay, versus the people oriented core specialties. All right, well, let's see what happened, okay? Let's take a look at the results. These are University of Arkansas medical science students, classes of 2001 through 2004, okay? Women are up here, scores, males down here, all right? The dotted line is the average between core specialties and the non-core, technical oriented specialties. And the same with the men. The average of the core and non-core put together. Women, for affective empathy, the national average is 60. They were not significantly higher than the national average. They hit it pretty much on the nose. Men, the normal, pardon me, is 29, but they came in up at about 38. So they were statistically significantly higher with affective empathy coming into medical school. All right. So for some reason, the males had a higher than normal affective empathy score. Now let's take a look. That's orientation, right? They're just coming in. The core women, they dropped a little bit. The women in the technical specialties, what they wanted to go into, really dropped. And then the males, we saw drops. In other words, when they took the B's scale at the beginning of their sophomore year, this reflects what happened when they were freshmen. And we see that things basically went to Hades in a handbasket. All the affective empathy dropped. Matter of fact, the males had the greatest drop. They lost over 20% of their affective empathy scores. All right. Down to a normal male population average. M3 time point, that's the beginning of the junior year, and it shows you what happened during the sophomore year. Things pretty much leveled out. Core women went up very, very slightly, non-core women fell very slightly, and it was the same thing in the males. So, what the heck was going on here? And what myself and my other physician colleagues came to the conclusion was, hey, I passed my freshman year of medical school. I know how to study. I know how to do this. I know how to play the game. I'm good. And so things really didn't drop. M4 time point is at the beginning of their senior year. The third year is when they are done with their bookwork, the didactic portion. Years 1 and 2, now they're in what's called their clinical rotations. They're out there doing 8 weeks of family medicine, 16 weeks of peds, 16 weeks of general surgery, right? They're getting a taste of all these different specialties. And we thought, before we analyzed the data, that things should go up because now, boy, they're finally getting to see their patients, right? They're dealing with people, they're out there. This is what a physician's supposed to be. Look at it. It really dropped. And that was a huge surprise and made a big splash in the academic world, right? Core women overall dropped 13%. Non-core technical specialties for women, almost 30% decrease. Male core, 25% loss. 38, almost 39% for non-core males. So those individuals going into more technically oriented specialties were losing more and more and more of their affective empathy. And I thought, well, this is horrible, right? Years go by, I leave. Well, no, sorry. Next slide. What about the specialties they went into? Okay. When you actually look what specialty they went into when they graduated, all right, the ones with the asterisk, those are your people-oriented specialties. OBGYN was at the top. Compared to a normal population, it was average. Peds, psych, family and internal medicine, all were average according to a normal population. Here's the normal population norm of 45. You put men and women together. All right. For some reason, dermatology was up there as average. But you look down here, you start to get into those specialties that are more technically oriented. Medical pediatrics are the physicians, the peds physicians working in the ICUs and with terrible childhood diseases and things. It's just not your general uh, pediatrician up here, right? So they had slightly low compared to the normal population. Path and orthopedists, moderately low. All right. Now, these are for individuals with an N out of the 419 greater than or equal to 6 so that you could get a standard deviation and do some statistical studies. We have those that went into specialties, less than 5 or less people went into these. So you really can't establish any statistical significance, but it just goes to show you that other than neurology, which was an outlier, it was actually slightly high. But once again, you can't put stats on it. And then it went down to ENTs, very low, plastic surgeons and neurosurgeons, extremely low compared to the normal population, right? Second percentile, 2 standard deviations off the norm. So that was affective empathy and what was happening. If you want to go into a people-oriented specialty, you better maintain your affective empathy. And as I took a look, as these students, what they wanted to go into as they went through their 4 years, it turns out if they started out with very high empathy and they wanted to be an orthopedic surgeon, by the time they hit their 3rd year, they were in the core specialties and had eliminated the technical non-core specialties, and vice versa. If somebody with very low affective empathy said, "Oh, I want to be a pediatrician, that's what I want to do," they would switch to a more technical um, specialty. So they were kind of sorting themselves out as they went through their medical education. Years later, I left UAMS, went to Campbell University School of Osteopathic Medicine, and I repeated the study. Again, I did affective, but now there was a cognitive empathy scale out there. And I did exactly the same thing. All right, 4 classes in a 435. The higher the score, the higher the uh, clinical cognitive empathy that individual would have. This is the cognitive empathy scale. All right. Here's orientation, people coming in, and here's the core women, women who chose the technical specialties, men, core specialties, men, non-core specialties. Looks entirely different than what we saw for affective empathy. Things really didn't drop after the first year of study. They dropped after the second year of study. For some reason, their cognitive empathy declined. All right. So I don't exactly know why that is happening, because as an osteopathic school, we really emphasize um, communication with the patients. I don't know what was happening. Here's after their first clinical year, right? Out seeing patients in their rotations. Core women actually dropped a little bit. Non-core women came back up. Core men dropped, non-core men dropped. So they're always dropping. What I didn't do in Arkansas, but was able to do at Campbell, was get these students about a week before they graduated, gather them all back up. And here we see things either leveled out, or in men, they just went up slightly. Turns out for women, these decreases are not statistically significant from each other. Males are. Their decreases are statistically significant from where they started out. All right. I'm not going to show you the affective empathy data, except to say that their scores did decrease, but not nearly as much as what we saw for students wanting to get an MD degree. Okay, there's the data. Things were going down. All right. Now, the goal for you as a future health professional is, how do you increase your cognitive empathy skills, communicating with the patient while not over blunting or dampening your affective empathy? All right. And I know, I'm sure many of you have had an encounter with a physician or other health professional where you wondered if they were even a human being. Their bedside manner was so horrible. I see some people shaking their head. Yes. You're like, what? Are you a person? But then you meet other physicians or health professionals that are so nice. They're just nice people, and they make a connection with you. And that's what you want to do. You want to be able to make a connection, but then understand you don't want to have so much affective empathy, it's going to impact you. And that's, pardon me, what I learned between being in Arkansas and then coming into North Carolina at Campbell University. The more I thought about it, the more I realized, well, maybe decreasing affective empathy to a certain extent, not so bad. And we'll understand why that's true just a little bit later. So how many osteopathic students increase their cognitive empathy while going through medical school while not over blunting their affective empathy? Well, here's the data in a scatter plot. This is affective empathy here, higher scores, much lower scores. And then here's your cognitive empathy, the Jefferson scale, very, very low, extremely high. Um, I would want somebody to knock down their affective empathy by 1/2 to 0.75 standard deviations. All right. Below the population norm a little bit, but also have an increase in cognitive empathy. And that's what I put the green box around. Now there's 400 and I think what, 35 dots there. In that box, I think there's 15. Okay, so very, very few students have or had the ability to be able to do that. So how do we get more students up here? If you're way up here, very high affective empathy and very high cognitive empathy, pardon me, you are in danger of severe burnout as a health professional. Opposite end of the scale, if you're over here, you may have half decent cognitive empathy, but wow, your affective empathy is, bad. This person down here, it's almost an outlier. Okay. I mean, very, very bad affective, very extremely low cognitive empathy. Okay. So this is the middle of the road right here where most people will end up. But you want to be over here. Okay. Can you teach empathic skills? Yes, you can teach cognitive empathy. All right. But teaching empathic skills has to be balanced between showing how to kind of damp down your affective gut response while maintaining enough cognitive empathy to establish a bond of trust. That's what you want, to establish an empathic bond of trust with your future patients. What's the best way to achieve that? Emulating a positive role model. If you can find a health professional in the profession you want to go into, and you find somebody that's very good at it, not only technically, but just personality wise, being able to communicate and connect with the patient, you emulate them. And that's the biggest thing a role model can play for you. I've heard many medical students come back after clinical rotations saying, "Oh, man, I really wanted to go into emergency medicine, but the physicians I saw when I was doing my rotation, they were awful. Right? A couple bad apples spoil the whole barrel. I don't want to go into emergency medicine anymore. It's awful." Okay. Or, I really didn't think I wanted to be a pediatrician, but during my rotation, that individual was so great, so nice. I think I want to do that too. Okay. So get yourself a good positive role model. Another way to do it is to be aware of yourself. There are two researchers, Reese and Kraft Todd, who developed an acronym spelling out empathy. And they have a little program or something you can get onto called empathics. Now, I talk about this, but I don't get any kickbacks or anything like that. I just think it's extremely clever, okay? Eye contact, muscles of facial expression, posture, affect, tone of voice. Hear the whole patient and then your response back to the patient. All right. Empathy, eye contact. Look the patient in the eye. All right. Especially when you're using what they call technological procedures. But for me, that also means what has been termed the third person in the room. You, the health professional, the patient, and the computer where you're charting things. You've got to remember to make eye contact with the patient. Muscles of facial expression. Patients can tell if you're anxious or you're busy or you're upset. Vice versa, you should be able to tell the patient using cognitive theory of mind and maybe affective empathy, a gut feeling you're getting that something's wrong here. Read their body language, your posture, sitting at eye level with the patient. Don't lord it over them. One thing I ding my medical students on during standardized patient is if they're talking about the plan they want to do and when to see me later, what's the follow up, and they're standing up over me and I'm sitting on the exam bed, right? They're talking down to you. Patients don't like that. Talk to them. They should be sitting in a chair, if anything, actually lower than you. Posture, mutual respect. All right. They can tell your body posture. Being able to make a mental note of the patient's affect. Are they pleasant when they come in? Are they really upset? Are they anxious? What's going to happen when you give them potentially bad news? What is their affect going to be? You have to look at that, use theory of mind to understand it so you can respond with cognitive empathy. And I'll give you some examples of that in just a moment. Dominant tone of voice, right? Be nice, okay? Hearing the whole patient, those nonverbal clues. Just don't come in and focus on their physical exam and the lab exam results and not talk to them like a human being. And then paying attention to your own response. Don't let negative feelings or anger or frustration make it a difficult encounter. Look at your own gut feeling or feel your own gut feeling. You're in the emergency room. Here comes a patient you've seen over and over again. All right, what's your gut feeling? Oh man, not again. Is that what you want to say to the patient after you use theory of mind? Oh, you again. What do you want? No, you can't do that. You shouldn't do that. You proceed with cognitive empathy and give the patient reassurance or whatever. So your affective gut response, that's your first signal to proceed with caution. So how can you do it? Sometimes you got to fake it. All right. Sometimes white lies are necessary. The example, okay, the emergency department encounter. You're on the healthcare team, patient comes in, serious car accident. You look at them, your affective, empathic response, that gut feeling is they're a goner. There's no way they're going to make it. They're going to die. Now, you got to use cognitive theory of mind. You don't want to tell the patient, well, sorry, you're going to die. Nothing we can do. That's not what they're going to want to hear. All right. Use theory of mind, cognitive empathy. They come in, you say, you're in the emergency department, you've had a serious accident, you're with a good medical team right now. We're going to do everything we can to get you through this and get you well. Just hang in there, even though you know it's a lie. But you're giving the patient some reassurance and some comfort, okay? The I've had the same experience, okay? Last Thursday, one of my clinical cases, I have three daughters, 20, 21, 23. When I said that, the medical student went, oh, I have three sisters too. Okay. Same experience type of thing. That makes a connection with the patient. Oh, they're just kind of like me in a sense. Or the patient says, man, I just smashed my thumb with a hammer. You say, I did that too once. Hurt like blazes, or we'll fix you up, right? May be a complete lie, but it reassures the patient. Additional comments, all right? That example, that the death in the family. Most of the students are looking down at their notebook, taking notes and say, oh, I'm sorry, or sorry to hear that. Follow it up with some statements. Oh, I'm sorry to hear that. That must have been a difficult time for you. Are you doing okay emotionally? Is there anything we can do to help you? You say something like that, you've got the patient on your side instantly. All right. It shows that you had some concern for that. I mean, that's really important. Or finally, taking a brief note to continue the conversation at the next encounter. I see an ENT once a year, and I'll come in December, and he'll say, hey, did you go to that blues festival? Now, you think he remembers that my wife and I go to blues festivals when he sees me once a year and he sees thousands of patients a year? No, what he probably did was take a very brief note in the chart. Hey, Newton likes to go to blues festivals. So when he comes in the next time, hey, did you get to go to that blues festival you did last year? Yeah, it makes that empathic bond of trust. Why is it good? It improves patient satisfaction, adherence to the treatment plans, builds trust, and actually better health outcomes if you make that empathic bonded trust. Why is it good for you? You can gather more information. You're usually happier with your job. You're less cynical. Cynicism goes up in medical school. Less likely to suffer bad burnout. And you keep patients from leaving to go to another physician. And it greatly reduces your risk of legal issues if you form that empathic bond of trust. But why is it too much empathy bad? All right. Too empathetic, more burnout, especially women. Women have higher levels of affective and cognitive empathy than men, and that can lead to burnout. More domestic issues. They cannot leave their troubles at work. As a health professional, most of the time you'll do wonderful things to help patients, but sometimes whatever you do just won't make a difference. All right. They aren't going to get well. They aren't going to get better. They aren't going to have those pains relieved. You can't take that home to work with you all the time. All right. It'll eat you up. And that's where, over the years, finally, when I got to North Carolina, I began to realize you do need to dampen down your affective empathy, that gut feeling. You got to learn to put that aside to a certain extent, okay? Because if you have too much of an affective response, it's been shown that the health professional is too busy thinking about their own emotional response versus giving all of their mental abilities to help the patient. They become less effective because they're thinking about themselves versus thinking about how to help the patient. Okay. So, got to learn to suppress it just a little bit. So, too much, and you have a person that alienates the patient and the healthcare team. As I mentioned, you probably have run into health professionals that just have no bedside manner whatsoever. So, finally, how empathic should you be? You have to harden your heart, okay, but not to a degree where it interferes with your communication skills, using your cognitive empathy. And as a health professional, you're going to walk a fine empathic line. And that's basically the title of a book chapter. I wrote, walking a fine line. Is it possible to remain an empathic physician and have a hardened heart? And the answer is yeah, but not so hard that you lose your entire bedside manner. All right. Yay. Questions. Awesomeness. Thank you for listening. And for those who are going to listen to this later, thank you too. Okay, I guess I quit sharing, right?
Yeah, sure.
So how do I do that? Oh, stop share. Ta-da. Point. There we go. Hey, folks.
Yeah. Thank you so, so much, Dr. Newton, for your amazing
Oh,
presentation.
you're
I really
welcome.
loved listening about empathy and how health professionals can incorporate that in their daily lives. One question I had for you is how do you personally maintain like clinical empathy when you're dealing with difficult or emotionally draining cases?
Well, that's where you you have to learn to blunt that affective empathy coming in, that gut response, that difficult patient. You have to uh, basically divorce yourself from the situation. All right. You realize, okay, this is going to be tough, but then you use cognitive empathy to try to convince them to change their lifestyle or whatever it is, and then not allow yourself to take that stuff home with you and let it eat you up. Okay. Maybe go back and realize how many people that day you did help and did have an excellent encounter with. I think most patients are going to be grateful that they have the time to be with you, especially when you can communicate with them effectively. Okay.
Mhm. Yes. So could you share like an example where clinical empathy significantly kind of impacted a patient outcome for you?
Uh, yeah. Okay. Uh, I'm not a physician, but when I was in Arkansas, I unfortunately wore a white lab coat in the hallway, and an adult and a young person, maybe 6 or 7, all right, stopped me and said, Doctor, my father's in the hospital and he can't talk. Can you help him? And so I looked up at the uncle or whatever, and he was like, bad, I'm like, okay. So what I had to do, since I'm an adult and this kid's, first grade or so, I sat down on the floor and leaned up against the wall and got to him face to face and said, well, I understand your father's here, but he's with a good medical team. We're going to do everything we can to help him, but we just don't know what's going to happen yet. And you just have to understand that right now. But you have other adults that are going to take care of you. All right. And it tore me up, which is why I didn't become a physician dealing with things like that. I mean, how many years ago was that? Good grief. And I still think about that, that really his his dad wasn't going to make it. Okay. But that was an example. Now, what was the question again, in case I didn't answer it fully?
No, that was it. Yeah.
That was good.
Hmm.
Now, good cognitive empathy was something that I saw when I was dropping my younger son off to preschool at a church in Little Rock, Arkansas. And I'm parked the car, he gets out, he's walking up the steps. All right. And I see two preschool girls sitting on the steps. And one of them starts to cry. And her little friend is sitting next to her. And the friend goes, what's wrong? And the little girl said, well, the doll came off my The head came off my doll. All right. And the other little girl said, well, I can't put it together for you, but I can cry with you. That's empathy, right? Has me choked up again. I mean, that's empathy, pro-social behavior, being willing to do things for people is ingrained in individuals by the age of 4. All right. There was a professor, Nancy Eisenberg, out in Arizona that followed children for 26 years, which is no way you could do a study like that
Mhm.
now. But by the age of 4, you could tell if somebody was willing to do something for a person without expecting anything back. Pretty amazing. Rats have empathy, right? Jeffrey Mogul, forget what university he was at, but take 2 littermate rats and put one of them in a clear plastic tube with a slide on it that could be opened from the outside. Now, it's not hurting the rat in there, but they don't like to be, squished into a plastic tube like that. Put a littermate rat in there, and they will go and they'll open that door and let the littermate out. But if it's a rat that's not a littermate, it will take much longer for them to respond to the distress of the rat in the little plastic tube. All right. So they were showing affective empathy. Here's something that's in distress. I have to help it. All right. So even mammals, other than us, will show at least affective empathy.
Yeah, those are really great examples of empathy. And I honestly didn't know that animals had that much of empathy. Yeah, that's
Hmm.
really great.
Yep.
So,
They'll
mhm.
uh, share chocolate chips. All right. Rats love chocolate chips. If you put a bowl out there and there's 2 litter mates, they'll be more willing to share out of that bowl than if it's a non-litter mate rat. Okay. So they will show preferential treatment to their litter mates.
Oh, I see Carolyn has a question.
Sure.
Hi. Can you hear me?
Yes.
Hello? Oh, okay.
Yes. Hmm.
It's a bit of a weird question, but it's something I personally struggle with, so I would like to know. I have this issue where my face doesn't match what I'm saying, no matter
Okay.
what I do. It's like dead face or something of the sort.
Okay.
I don't know, and I feel like that makes me seem less genuine than I'm actually being. And I would really like any tips on how to improve that.
Sure. What you're doing right now, altering the tone of your voice. It's not monotone. It has inflection to it. You can have emotion to it, and you can use your body language as well. Okay, you wouldn't sit back in your chair with your arms folded and talk to the patient. You can come up, put your elbows on the table, hold your hands in a way, or express, right? You can use a lot of body language as well. Okay?
Hmm. Yeah,
Don't
so
let,
like the
what?
contrast between no face language and a lot of body language wouldn't be weird or something?
Um, no, I don't I don't think so, not overtly. If you're there to help patients, they're there to listen to your advice and your technical skills on what you are doing. If for some reason you feel that the lack of facial expressions would be a hindrance to your health professional career, there are a lot of technical specialties that you can go into where there is no patient contact, right? Pathology, radiology, uh, nuclear medicine stuff, a lot of things. or you don't have to be face to face with the patient if you feel that what you have is a hindrance for your ability to communicate. But you're
Thank you. That's
communicating
great
well with them.
advice.
Pardon
Thanks.
me?
Thanks. That's great
Oh,
advice.
you're welcome. A little audio delay there. Yeah, you're welcome.
And another question I had was, what strategies do you recommend for healthcare professionals to prevent empathy decline?
Well, a little bit of empathy decline is good. As I say, you can't allow these certain interactions to eat you up. But it's the cognitive empathy, and that's reminding yourself of that acronym empathy, right? The eye contact, your posture, your body language, and also learning how to communicate. Um, there are numerous things that they have done to medical students to have them appreciate what a patient's going through. For example, if they're in a geriatrics rotation, which is becoming more popular now, they'll make the students wear eyeglasses with some Vaseline smeared on them to mimic cataracts, put earplugs in, wear 3 or 4 pair of socks in their shoes, or put a pebble in their shoe, all right, to see what it's like to have foot pain, all right, can't hear well, can't see, uh, wear a bunch of weight to mimic obese patients, things like that, so that you put yourself into the patient's shoes, so to speak. Another way to increase it is to uh, basically have a diary, write down your emotional responses to interactions with patients, writing essays, getting together in small groups that is closed session where everything stays private. What you say in that session stays in that session. And then you realize that other students or other health professionals, if you're out in the real world, have the same issues that you do. And you talk about strategies to overcome certain things. Valent sessions is what they are called. Um, that's all I can think of right now. Learning communication skills. All right. Not being afraid to talk to the patients and looking them in the eye.
Yes, those are some really great strategies. Thank you so much for that.
Sure.
Now I'd like to pass it on to Haviland, our Q&A lead.
Sure.
Hi, y'all. We have some questions in the chat that I
Hmm.
can read off, but if any students would like to ask their question out loud directly to Dr. Newton, feel free to raise your hand and then I can call on you. Other than that, we'll just start from the top. Preston, I see you have your hand up. The floor is yours.
I have a 3-year-old and a 2-year-old running around in the background, so you may hear some small voices.
That's
Um,
okay.
no, I previously served as a first responder. I was a firefighter. I have brothers that are cops, and that empathy you talk about, that I know some of the like die off is kind of good, but I saw a lot of like jaded or hardened hearts, as our chaplain would put it. Like a lot of those. Oh man, the same address. We're going there again, rather than like, okay, hey, this might actually, be an important call. Um, and I'm actually in some psychology classes, and I was recently thinking about this through the lens of locus of control. Um, and specifically, I was looking at high versus low, and then raw versus defined locus of control. And I was wondering if you think that that might have any impact on the fall off of empathy for providers and clinicians, as well as, if there are any like educational or structural interventions that we can use to protect our empathy, to keep it from dying off too much. Obviously, like you said, some of it's good, but we also don't want to completely harden our hearts as well.
Um, I'm not a sociologist or a psychologist. I'm a basic scientist and anatomist. Um, but I think talking it over with others in your profession is a good way to do that. And having that natural gut response of, oh no, I'm going to the same address again, that's just natural. All right. That's your primitive nervous system responding to a situation that you've been in before. So that's when you got to think about it, unless you say, well, maybe this time it'll be a little bit different. But not to become completely jaded, it is going to be tough. That's why there's a certain degree of burnout in certain professions. Um, I guess you try to find something to relax when you get home, a hobby or some way to decompress that's legal. Okay.
I mean,
Yeah.
I burnout is a huge concern for me. I'm trying to go into emergency medicine, and I know it is as far as specialties go, one of the highest burnout fields. Granted, I have a background that I think primes me for it more.
Oh, yeah,
I think
sure.
I know I'm getting into, but I don't think I'm immune to it. Like I said, I've had the same house 2 weeks in a row, where it's just this is the seventh call. Are we serious? And had to remind myself on the way there, hey, this could be the big one, you know. So, but I appreciate your input. Thank you so much.
Yeah. You're using theory of mind. All right. Yeah, but this could be the big one. So you're thinking about it, all right? It's just not an affective gut response all the time. So you're well on your way to becoming the health professional, even more so when you realize that in yourself, that you got to damp some of those feelings down. That's great.
Appreciate it. Thank you.
Oh, sure. You bet.
Next question we have in the chat is, do you think the sudden drop in empathy at the start of the fourth year could be due to exhaustion? This student heard that rotations can be tough on a lot of MD students.
Yeah, sure. A little bit of that, but you would think that would be counteracted with the fact that they're able to see patients that they desire. All right. Now, for the affective empathy, that drop was pretty significant. But if you look at cognitive empathy, though, in the study at Campbell University, actually the scores rose some uh, at the end of the fourth year. So they were learning, I think, to better communicate, but also during the fourth year, they get to take elective rotations for things that they really like to enhance their ability to get the residency they want. So maybe things go up a little bit because they really are finally getting to see individuals that they want to treat in the future. Now, why the empathic affective response bottoms out after that first clinical year back in Arkansas, uh, part of it could be to exhaustion, but not all of the students take the same rotations at the same time, right? A certain number will be in peds, a certain number in family medicine, a certain number in radiology. So it's all mixed all over the place throughout the third year, fourth year as well. So um, I think that may ameliorate or reduce the effects of exhaustion to an extent. All right. But I think exhaustion can play into it. A little bit of burnout, actually. Maybe realizing that, oh my goodness, this isn't like Grey's Anatomy or the other 15 or 16 medical shows that are out there. It's called traumatic de-idealization. It was a paper written by last name of K back in, I think, 1990, where they get into the profession they want, but they realize it really isn't what they expect. Okay. And maybe there's a little bit of that going on too. But I think exhaustion can play a role. It's hard work.
Yes, it sounds like it is. And thank you for that. I've never heard that term used before, but I would imagine realizing that Grey's Anatomy isn't as accurate as we might think could be jarring for some folks.
Um, yeah, go on to Google Scholar or type in Kay. I forget the first name, and then traumatic de-idealization, and the paper should pop up. It's fairly short, but it was an interesting read. I reference it quite a bit when I was writing book chapters and uh, scientific papers.
Great, thank you.
Sure.
Our next question asks, I believe you touched on this a little bit in the presentation, but they're asking, what is the difference between questions that measure cognitive empathy and those that measure affective empathy? Could you provide
Oh,
examples of both?
yeah. Oh, uh, like affective empathy um, would be a question that would be like, um, you feel that people are responsible for their own illnesses. Yes, Likert scale. Extremely disagree, extremely agree, and everything in between. Or sad movies make me cry. Okay. Uh, the laughter of children brings me joy. That's questions about affective empathy. That's the B's Balanced Emotional Empathy Scale by Albert Morabian. Um, Cognitive empathy, that clinical empathy. Yeah, I wish I had the papers right here. I'm trying to think of an example. Um, Half of them are negatively worded, and the other half positively worded. So you can tell if a individual is just faking it when they bubble in their answers. Oh, what is it? A physician should use a calm tone of voice when speaking to the patient. All right, those questions were directed right towards health professionals. The physician should encourage talking with the family for certain medical conditions. Questions like that. If you go online and look up Jefferson scale of empathy, you'll probably be able to find the whole scale and the questions that were asked. There's a student version, there's one for health professionals, but they're aimed towards the health profession. The B scale was made for, quote, a normal population because Dr. Morabian was a psychologist and he uses them in his practice. I was fortunate enough to get it back in 1996 when it first came out. I had to look up empathy, right? The physicians told me, hey, do this. So uh, I ran across his name, I guess, and I emailed him and I said, could I use it for educational purposes? And he went, yeah, send me $5. So I've used it since 1996 to just a few years ago. But he does not give it out to everybody. I was just fortunate enough to be able to get a hold of it. So it's made for a normal population, not exactly for health professionals.
Right. Thank you so much for providing those examples. Our next question in the chat asks, do you believe that formal training in empathy, specifically cognitive empathy and affective empathy, should be a standard requirement in the healthcare education to improve patient care and professional success?
Yeah, in in a degree, they I don't think you can really enhance affective empathy. That's pretty much built in. It's a very primitive response related to the pain axis. So I don't think you can teach that, but you have to kind of know yourself to blunt it. Okay. Now, cognitive empathy can be taught, and there's lots of different ways to do it. Dr. Hojat uh, has a book out, third edition, on clinical empathy. But most of the studies that have tried to enhance cognitive empathy, the results last 6 weeks to about 6 months. Okay, these are taking classes and small group sessions, things like that. So the advances, the increases are kind of short-lived. So you have to keep doing them over and over. In the curriculum, pardon me, probably take way too much time. But what you can do is introduce the students to the theories of empathy and then really emphasize communication skills when you're dealing with standardized patients and doing the histories and the physicals. That's what we really harp on, at least in our osteopathic school at Campbell. Learn how to communicate. So, as a pre health professional, the best thing that you can do is learn how to give or get good communication skills and how to speak to another person and look them in the eye, okay? And your body language and making people confident in your decision making. Okay. If you appear confident in your decision making as a health professional, then that will rub off on the patient as well. Okay. So there are ways to increase it. Hojat, I think, wrote a paper called 10 Methods to Increase Empathy. Go on to PubMed or Google Scholar, type in Hojat, Hojat. First name is Muhammad Reza. So Hojat M, and then empathy. And he's written hundreds of papers. Or type in 10 ways to increase empathy, Hojat. And hopefully that paper would pop up for you. Or you can read one of my chapters, you can do that. I don't get any kickbacks. You pay to publish.
Thank you for those resources. Appreciate you
Okay.
sharing those with our team. And I think our last question in the chat asks, how do you prevent stuttering and speaking too quickly before you speak to patients?
I used to stutter. Um, you, your thought process is running faster than your vocal abilities. So you have to slow down your thought process just a hair. And that was the first part of the question. The second part was I
I think it was prevent stuttering and speaking too quickly.
oh, okay. Yeah, yeah, some of the students, as a standardized patient, they do talk too quickly. I just simply tell them slow down a little bit. Okay, maybe use a little bit of body language. That motor skill tends to slow things down a little bit. All right. Uh, Hopefully, you'll grow out of stuttering. All right. Uh, it's something that I grew out of, but how I did that consciously, I don't know. Okay. Become more comfortable speaking in public. All right. James Earl Jones used to stutter, right? The great actor who recently passed away. Uh, but he did Shakespeare and everything else. So it can be done. Or you can go to a speech therapist. Speech therapist can help with that as well. Okay? So it can be overcome. You can do it. Okay?
Yes, thank you so much, Dr. Newton, for the excellent presentation. And your research on empathy decline in medical school and the distinctions between affective, cognitive, and clinical empathy were really valuable. So we really appreciate your time and expertise. So let's move on to our wrap-up slides for today. And I'm just going to present it right now. Sorry. Okay, cool. So the three questions we have for all participants today are what are your favorite moments or examples from today's session? What idea from today you're most excited to explore next? And what's one key takeaway or idea that stood out to you the most? Feel free to answer these questions in our chat or the PHS portal. Also, feel free to share your insights on LinkedIn today because sharing your involvement in tagging PHS will help you and us expand our professional networks. And you can tag us at pre-health shadowing on LinkedIn. Once again, if you are interested in being part of pre-health shadowing, just go to our website and sign up for a position and an interview, and we will reach out to you as soon as possible. And lastly, if you can, please, consider donating to PHS, even $1 or a cent. If you can, it would be really great because donations are the foundation of PHS. And if you can't donate, that's fine too. You could volunteer your time with us, and that's equally valuable. Lastly, don't forget to take the shadowing assessment today so then you can actually get an actual certificate for the time you dedicated this. And if you missed a part of our session, no worries. You can just visit our YouTube channel at Rehealth Shadowing and watch any of the previous sessions or today's session for free. Thank you so much. If you have any questions, feel free to stay back. Yes.
Okay. You all have a good rest of your day. All right.
Yes, thank you, Dr.
Thanks, Dr.